Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber. Welcome back, everyone. We are going to have a look at an interesting paper on neoadjuvant treatment in rectal cancer today, and Prof. Saba is going to talk about limitations of RCTs and biases that can affect them, continuing on his previous lecture. I'll leave you to it.
So I'm Sean. I work in St James's with Gio as one of the regs. I work as a junior clinical fellow, and we are reviewing the watch and wait after neoadjuvant treatment in rectal cancer, a comparison of outcomes in patients with and without a complete response at first reassessment in the International Watch and Wait database. So this was a recent publication in the BJS in 2023, and the link's just there to it. So just on to a bit of background about it.
Absolutely. So we do know that more and more often we are providing patients with neoadjuvant treatment before proceeding to surgery for rectal cancer. And with the evolution of radiotherapy, chemoradiotherapy, and chemotherapy, we have now developed a fairly standardized model of a total neoadjuvant treatment whereby patients are given chemoradiation and chemotherapy and then are assessed clinically and radiologically to determine whether they've responded to treatment. And it has become more and more evident, but has been known for many years, that a lot of patients actually respond very well to this treatment, to the point where the cancer pretty much disappeared on both MRI and endoscopy. And it has become reasonably established to watch and wait some of those patients to see if this complete clinical response actually persists in time. A little bit less clear is what to do with the near complete clinical response. And what you can see here represented in this chart is the OPERA 3-tier clinical response assessment scheme, which comes from the OPERA trial, which kind of contributed to the popularization of TNT. Now, this paper tries to look into what happens to patients that, following a variety of different types of neoadjuvant treatments, end up having a complete or a near complete clinical response and determine what happens to them in time. Now, I'll pass the ball back to Sean for a little bit more about the aims of this paper.
Perfect. So the aim of this study was to compare two different groups of patients. So ones that achieved a complete clinical response at first assessment versus ones that achieved a complete clinical response at a later assessment from the Watch and Wait database, which was made in 2014 and has kind of retrospective and prospective data that they put on. And they defined a near complete clinical response as on MRI as an MRTRG of 2 or more, or on endoscopy. With ulcer or polypoid tissue or stenosis endoscopically. So we just put it in PICA. So I'll pass it back to Gio.
Yeah. So obviously, this is an observational data set study, so PICO doesn't necessarily marry very well with this, but we did it anyway. We could say that the patients included here are patients who at some point achieved a complete clinical response after having had some sort of neoadjuvant treatment of a variety of kinds. The group that we are sort of experimenting on, if you like, or that we are watching in terms of comparing their outcomes compared to what we normally do, is people that did not have a complete response on the first reassessment, but were kept on a watch and wait protocol for longer and then achieved that clinical complete response. The comparison, so the standard of care, would be patients who achieve a clinical complete response at the first reassessment after having had the neoadjuvant treatment. The outcome they look at is organ preservation, which basically means retaining the rectum without an operation of any kind that would obviously remove it. Absence of a local regional regrowth, unless a salvage procedure with a transanal excision is performed, which again means only removing the lump without removing the actual rectum. They also look at other outcomes such as distant metastasis, free survival, and overall survival. And we'll go into some more details about that later. So ball back to Sean for some methods.
So like Gio touched on, it's an observational study, and it collects data from the Watch and Wait database. And so that's a international multi-center database using retrospective data. So it included patients collected from 1991 up until the 1st of April 2022. And it included all patients that ended up having a complete clinical response, whether that was at first assessment or at a later assessment. And this was based on both MRI and endoscopy. And sometimes they also used TM during follow-up as well. But excluded were those patients who were unable or refused to have operative management, so were off that first, or and then went down the watch and wait because they couldn't or refused to have the operative management. And also patients who didn't have both MRI and endoscopy. And then they just used organ preservation as their main outcome, as we put in PICO. So let's pass it back to Gio.
Wonderful. So as you can see in the data set, they had just above 2,000 patients. After a few exclusions, predominantly related to incomplete data or application of exclusion criteria, they end up with about 1,000. 600 end up having a complete clinical response to the first reassessment, and 400 end up having a complete clinical response at a later reassessment. So 600 versus 400 in total. And ball back to Sean for a bit more about results.
So these are the characteristics that they compared between the two groups. There are some statistical differences, especially comorbidity, which is relevant because it shows that the complete clinical response patients that were found at a later reassessment, so they had high amount of comorbidity present in the patient sets, and also the baseline T and baseline N. With this, it's not necessarily applicable to the UK and Europe because often with T1 and T2, and especially even T2, even with N1 disease, it's operative management is usually the first line, and T2 N1 is sometimes considered operative management is considered first, and that's kind of the UK and Europe baseline that they tend to go for. So, and there's quite a high amount of patients with T1 and T2 in the CCR at first reassessment. And then it just shows that there's no difference in the induction therapy, but there is kind of a large amount of different therapies that patients in the study received. And so I'll just go on to the results and outcomes. So their primary outcome of organ preservation. So they didn't see any difference in organ preservation, distant metastasis-free survival, or overall survival. And their median follow-up was 2.6 years at first assessment and 2.9 at later assessment. However, overall survival is probably the most reliable because it doesn't depend on how often these patients are followed up, whereas the other two do. And organ preservation, although it's slightly more reliable than distant metastasis-free survival, because local reoccurrence tends to happen within the first 2 years. It's still not ideal because it does depend on kind of the how well it's picked up endoscopically, and also how often patients are being followed up, and then distant metastasis-free survival. And these can often happen up to 5 to 10 years later down the line, so some patients will be missed by this. And I'll just go to the next slide. And so back to Gia.
Wonderful. So in the next sort of 3 slides, we'll have just a quick look at how this authors subclassify the near complete clinical response based on MRI data, endoscopy data, on both modalities data. So whichever one of them picked up that the response was not complete. And as you can see, there is sort of slightly worse outcomes for people that have a near complete clinical response on both modalities, so both MRI and endoscopy, and slightly better for the other 2 groups. That does not necessarily translate in terms of distant metastasis-free survival or overall survival. This subgroup analysis is rather inconclusive, if you like. And as you can see, if you then look at the actual numbers, especially if you start hitting 4 or 5 years, the population at risk that remains in the study becomes fairly small on pretty much all 3 outcomes measured. So ball back to Sean for some more limitations.
So the self-reported limitations of the paper were patients who had a near complete clinical response, but who never quite achieved it, just could not be included, which could be quite a large data set, which would be a good comparison that just weren't included in the paper. And it did not include patients with near CR who were referred for surgery. And for an initial kind of when they first noticed it, and just referred immediately to surgery, and did not achieve a complete clinical response.
We picked up a few other things as we were going through the paper. Well, obviously, this is a data set study that starts from 1991 and carries on to 2022. So there obviously is a degree of selection bias. Patients are included in the data set based on different criteria that have evolved over a period of over 30 years, actually. I believe there is an issue with stage migration bias because certainly, particularly MRI technology, but also MRI reporting checklists, as well as endoscopy technology, have changed during the period of the study. So I can't imagine the accuracy of those staging investigations, particularly nodal assessment, would be equally accurate across the study population. There will be some differences. It is nearly impossible to figure out what type of neoadjuvant treatment these patients had. The paper doesn't mention it. The data set probably doesn't collect data to that level of granularity. So we are unable to really say what worked best or if there was an actual difference. So if patients had any additional treatment after their first reassessment. As Sean mentioned, I'm not entirely sure what the indication is for neoadjuvant treatment in T1 and T2s. A bit hard to say whether these patients were sort of included here in as part of experimental studies in early stages of the development of neoadjuvant treatment for rectal cancer. Another very important point that relates to sort of the time span of this study is that transanal salvage availability certainly wasn't there in the 90s, and certainly has found its introduction in routine clinical practice only with time, and certainly has become more and more available in the past few years. So not every patient was offered that possibility or had that sort of procedure as a potential additional treatment when after having the neoadjuvant treatment. We did discuss what the most reliable outcome here, and I think it's reasonably evident from what Sean mentioned that we do think that overall survival would be in the context of a study that does have no clear-cut protocol on follow-up or clear-cut follow-up investigations, or a timeline for those investigations would be probably the most reliable one, overall survival. I had a quick look at the data set validation and the data set sort of layout. I couldn't really find much out there. The authors don't really talk about it, so I'm not sure how well validated the study is. It's worth mentioning that the data set started in 2014, and data before 2014 was inputted retrospectively in the data set. And I'll give you that only a marginal fraction, about 100 patients who were included retrospectively before 2014. Still a reasonable number. Right, and Sean, do you want to wrap it up?
Yeah, so our bottom line was that the outcomes between the two groups seemed comparable and there was no kind of significant difference between them. However, the methodology and the clinical limitations of this paper make it very difficult to apply to current practice that we use in the UK and in Europe. So the good points that we said were we had a large sample size and it was a multi-centre data set, and in clinical it's a hot topic that people are talking about, and the primary outcome choice was good, and it did include kind of overall survival as well. Bad parts are it does have selection bias in terms of retrospective data, and it was some of the data was inputted retrospectively. So from 2014 back to 1991, and also the stage migration bias that Gio touched on as well. And there is no morbidity data, so patients who had radiotherapy and so radiation proctitis, so there's nothing on that in this paper, and also the inclusion of TAMIs as well.
Thank you.
Thank you.
As usual, a quick summary of what we discussed after the paper presentation. On top of what we mentioned, particularly in relationship to inclusion bias and stage migration bias. On a side note, if you're interested in this, have a look on our YouTube channel. There's an episode on biases in observational studies. We discussed the fact that this particular study could be affected by mortal time bias. This is particularly evident when looking at the survival curves that tend to have a flattened appearance in the sort of earliest part of the curve itself. Immortal time bias happens when patients that are included in a study have a survival advantage over patients that are otherwise affected by the same condition, not treated in the same way, but due to their unfitness, do not survive up to a point where they get included in the study. In this particular case, it would be that patients that are treated with neoadjuvant treatment and due to their comorbidities or intolerance to treatment don't survive to the point where they can be assessed the first time. And this could significantly affect the survival analysis. We also discussed how there is overall in this paper, we feel a lack of a meaningful denominator. Patients are included based on the RAND outcome, aka the achievement of a complete clinical response at some point. It becomes then very difficult to take this data and use it to counsel patients when they are in the process of getting neoadjuvant treatment, have not achieved a complete clinical response, particularly when patients that have been deemed unsuitable for surgery have already been excluded from the study and patients. So this can further bias the result of the study. I'll leave you to Prof. Sabba's presentation.
Trials before, and I think last month we talked about a couple of limitations of randomized controlled trials. In fact, I've got a slide here that is a summary of the previous talk. And we talked about how some of the results of RCTs may not be generalizable. We talked about that with an example from a paper from the New England Journal of Medicine on the role of iodine in low-risk thyroid cancer. And we talked about how results of RCTs are not often in sync with results of observational studies or even database studies. And we talked about how with RCTs there is a significant obstacle in studying long-term outcomes, and how sometimes short-term outcomes might favor one treatment while long-term outcomes may favor the other treatment. So those are the things we talked about as some important limitations of RCTs. And today I thought we should talk about the so-called trial effects in RCTs. And I'll start off by giving you an example, and I might just give you 1 minute to write in the chat box what you see as the potential reasons for a particular observation. I'll explain that in a second. So let's just imagine that you are either designing or you're conducting a multi-centered RCT where you're comparing laparoscopic surgery versus robotic surgery for colorectal cancer, and you're really interested in disease-specific survival and perhaps quality of life as well. And then you've done this big study involving, say, multiple centers in the United Kingdom. And let's then see the outcomes in patients who are taking part in the trial, regardless of whether they have the lap or the robotic surgery, versus patients who, for various reasons, are not in the trial. Either the patients didn't want to take part, or the clinicians thought they're probably not suited for the trial, or they just didn't meet the eligibility criteria. And let's assume that the trial showed, as many trials do show, that, or your analysis showed that trial participants seem to do better than non-trial participants. So it's not to do with whether they had laparoscopic surgery or robotic surgery, but just overall patients within trials have done better than patients that are outside of trials. Now, why do you think this would be? What are the potential reasons why trial patients are doing better than non-trial patients? Do you mind just putting whatever your thoughts are in the chat box, and maybe Gio can summarize? Hawthorne effect, yeah. I'll explain the Hawthorne effect in a bit. And then people with motivation and concerns about the health may have other attributes that make them generally fitter, more tolerant of treatment, and stronger, and therefore these are probably the patients who will be in trials. Yeah, that's good. Any other reasons? So there can be a number of different reasons, and that's what we're going to talk about now. So what would help is trying to categorize or box these reasons into two major categories, right? So the first category is what I would refer to as the cohort effects. Yeah, this were some more reasons in the chat box. That's good. So what do I mean by cohort effects? By cohort effects, I simply mean that there could be differences between the patients in the trials and patients outside of trials. And that could be because of the eligibility criteria. Patients have to meet certain eligibility criteria before they can take part in the trial. There could be some factors that are not really documented, whereby the clinicians are a bit concerned about patients entering into this trial. Some clinicians might think that this patient is neither suitable for laparoscopy nor robotic, and therefore might be unwilling to enter them into the trial, or may not have broached the topic of trial participation. And sometimes patients, for various reasons, might just not want to take part in the trial. They might be suspicious of getting involved in trials, and so on and so forth. So you know these reasons. So these are all reasons how non-trial participants can somehow be quite different to trial participants, despite having, colorectal cancer and despite having various other similarities. So there could be differences between cohorts. Yeah. The other set of reasons are grouped under the category of trial effects. So under this category, there are four distinct points to consider. One is that for one reason or the other, the trial participants get better treatments or better care. The other reason is what we refer to as the protocol effect, and I'll explain that in a second. Then comes the Hawthorne effect, which one of you mentioned, and finally the placebo effect. So what we'll do in the next few slides is to go through each of these trial effects in the context of the example we've just discussed. So the example is a multi-centered RCT comparing lap versus robotic surgery. So what about different treatments and differences in care? So it could be that patients in the trial allocated to either robotic or laparoscopic surgery are likely to get their surgery from expert high volume surgeons. It could be that the trial itself stipulates that if you are getting into the trial and having robotic surgery, then the surgeon should have done 20 procedures or something like that. Or the surgeon should be a high volume surgeon doing more than 10 or 20 or 30 laparoscopic surgeries a year. And that may not necessarily be the case for non-trial participants. It could be that trial patients had more frequent follow-ups, as you mentioned before. And it could also be that trial patients have more contact with research staff, more often minor discrepancies in results are picked up while filling in the trial documentation. You're more likely to act upon these minor issues that are picked up in the labs or on scans. And those factors might influence outcomes such as survival and quality of life. The next kind of trial effect is the so-called protocol effect. As you probably already know, trial patients are subject to a very well-defined set of instructions, or we call that the protocol. And this protocol could stipulate how surgery is done, sometimes steps of surgery, specific aspects of preoperative care and postoperative care. And all of that, dotting the I's and crossing the T's, in terms of following the protocol, will potentially favor the participants in the trial. Sometimes trial protocol mandates extensive screening for sepsis and other risk factors for perioperative morbidity that you may not necessarily do in the average non-trial patient. And the protocol often mandates quite rigidly when adjuvant treatment has to be initiated, when patients have to be followed up. And this is not often the case in our bog standard NHS patient, where logistics and resource constraints can often influence when the patient gets their adjuvant treatment, unfortunately. So these are all referred to as the protocol effect. The next effect is what you mentioned. One of you mentioned the Hawthorne effect. So I'll give a bit of a background. So essentially, the Hawthorne effect refers to the phenomenon or the impact of the awareness of being observed on the behavior of either the trial participants or the treatment or care providers like the surgeons. So it was first described by a chap called Landsberger in the US, who looked at data from a number of studies done on a factory in Chicago, the Hawthorne Works, in the 1920s and 1930s. And what they did is they evaluated the impact of different interventions on the output of their workers. And the interventions would be things like giving them breaks, 5-minute or 10-minute breaks, giving them snacks or food at breaks, shortening the work days, changing the illumination of the factory, and so on and so forth. And the interesting thing is that regardless of the nature of the intervention or the direction of the intervention, output would increase in the factory. And this has been attributed to changes in the behavior of the workers as a result of their knowledge that they're being observed and their output and their production, the produce is being counted. So there's been a lot of debate on the design of these studies and how the data has been interpreted, and several other factors other than this impact on behavior has been postulated. However, this is a really important effect and has got significant parallels in medical literature. So coming back to medical literature then, interestingly, there's been a study on the Hawthorne effect, a direct assessment of the Hawthorne effect, not in surgical literature, I have to say, but in neuropsychiatric literature, whereby what they did was they got hold of a big group of patients with dementia, and they randomized the patients to a herbal product called ginkgo biloba. It's basically a supplement from a plant species that is native in China. And they randomized patients to either receiving this herbal supplement or placebo. And they also randomized in a 2x2 factorial design, the same group of patients to either receiving intensive follow-up or minimal follow-up. And they, at the end of the study, they looked at cognition. And the interesting thing is that the herbal supplement did not affect cognition, but the cognition was improved in the group of patients who had intensive follow-up. And by intensive follow-up, basically meant more frequent assessments of the patients. And the authors argued that this is evidence of the Hawthorne effect in that the participants knew they were being observed more closely and being monitored, and they're doing the best to put up, and come up with a better sort of cognitive performance. Right, so back to our example, laparoscopy versus robotic surgery for colorectal cancer. So how could the Hawthorne effect be applicable here? Now, surgeons, if they are being aware of the scrutiny associated with the trial, it is possible that the expert surgeons or the senior surgeons did most of the operation and didn't allow or give much of the operating to the trainees. It is possible that they paid more attention to every step in the operation, consciously or subconsciously. And it's not just the surgeons, but also the anesthetists, the physiotherapists, the intensivists, may have potentially provided, provided more attention and followed the various aspects of perioperative care a bit more rigidly, because they know that all of the outcomes and the interventions are being documented and scrutinized as part of the trial. So, so you can see how the Hawthorne effect can play a significant role, not in biasing and causing differences between the lap and robotic arm, but just increasing the chance of a better outcome in patients taking part in the trials overall, regardless of the arm to which they have been randomized to. The final effect, the trial effect, is the so-called placebo effect. I'm sure you all heard of the placebo effect, which essentially refers to the phenomenon that patients do well because they perceive that they're getting new treatment, a novel intervention. They've been looked after more. They've been followed up very carefully. They've got the contact of the clinical nurse specialists and the research nurses. So regardless of whether they're getting a laparoscopic or robotic arm, they might feel that they're getting specialist or additional treatment. Now, there's not much in the surgical literature with regards to the to empiric data on trial effects in surgical trials, but it is a good study in the medical literature, and then I've provided the link there, where they looked at patients, HIV positive patients who participated in trials of highly active antiretroviral therapy, and compared these patients to patients with HIV who did not take part in the HAART trials, but received routine clinical care, which would have included these antiretroviral agents. And they found really good evidence and that there was a difference in the viral load, in that patients within trials did better and had a much reduced viral load compared to patients outside of trials, regardless of what treatment they received. Right, I wanted to conclude by just mentioning the halo effect. The halo effect is different to the trial effects we've discussed so far. I was also under the false impression that the halo effect is also a kind of trial effect, and that is not the case. Essentially, it's a phenomenon whereby you have a single trait and you take that as being reflective of other attributes in a particular patient or person or thing. Now, a classic example would be, a smartly dressed person at an interview being perceived somehow to be better at his or her job based on their presentation and appearance, whereas we all know that that's not necessarily the case. So how does that have an influence on surgical research? So in relation to surgical research, one of the things that may impact on your perception of how good a study is the journal's impact factor. Like the article we've discussed today, the paper is published in the British Journal of Surgery. It's got a very high impact factor. So even before you read the paper, you may attribute a high level of importance to the paper simply because it got published in the British Journal of Surgery. Typically, if you see a randomized controlled trial in the Annals of Surgery, which has a very high impact factor, you're probably going to pay a lot more attention to it than if you come across a RCT in the Annals of Royal College of Surgeons of England. And I wouldn't blame you for that. But you've got to keep in mind that there is a bias there. And there's been an interesting study in sepsis, in the sepsis literature, where authors essentially evaluated a number of factors that influence subsequent citations, and they found that journal impact factor, not the study design, or not another sort of measure of quality, but it was a journal impact factor that was an independent predictor of subsequent citations of those individual studies, which goes to show that there's clear evidence that there is halo effect, and that journal impact factor does significantly influence, more than study design, does significantly influence what readers think of an individual study. And that's a paper there, a link to the paper if you're interested. Right, so I'll summarize. Essentially, you've got to keep in mind that there's a lot of evidence out there that just participating in the clinical trials, regardless of which arm you get into, the placebo arm or the standard arm or the intervention arm, on average, patients seem to do better in many scenarios, not in all scenarios, but many scenarios, they seem to be doing better than non-trial participants. And this could be due to a variety of reasons. It could be very simply that these are very different patients. So that's what we refer to as the cohort effects. But it could also be due to the so-called trial effects, which, as we have just discussed, you can summarize as the effects of different treatments or care, and the effects of following a rigid protocol, the Hawthorne effect, the fact that people are being observed, and the placebo effect, patients thinking that they are in the trial and probably therefore everything is being done as per probably a higher standard. And finally, remember the halo effect when you're coming across papers and when you're looking at what journal the paper got published in. Thank you very much.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.